Assalamualaikum and a very good afternoon to all of the webinar participants for today. First of all, actually, I thank all the participants for actually joining us today for the first CEP-SIG clinical toxicology webinar that we conduct since SIG clinical toxicology was developed in 2022 or 23. So today we are fortunate to have one of the speaker that will actually enlighten us with the topic of clinical monitoring in snakebite, doing it right. So with us today we have got Dr. Anas Amri bin Hashim. Dr. Anas Amri bin Hashim actually is an emergency physician in the MOH Malaysia since 2016. So he's graduated from National University of Ireland, PMC, and also obtained his Master of Medicine, Emergency Medicine in 2016. And he is a member of Academy of Medicine, College of Emergency Physician Malaysia, starting from 2022 onwards. So he has actually vast experience as instructor in BLS, ALS, TLS, and also APLS. A bit of experience that Dr. Anas Amri actually had is that he actually becoming the emergency physician initially at hospital Sultan Haji Ahmad Shah Temerloh, and then becoming a head of department and emergency physician in Hospital Sarike for quite a long time. And then currently he is actually serving the Hospital Sultan Abdul Halim Sungai Petani Kedah. So with that, I welcome Dr. Anas Amri to deliver his talk for today. Thank you.
Hey, Assalamualaikum and a very good afternoon. Thank you, Dr. Rosabrina, for the kind introduction. So let me share my screen first. So can everyone see the screen? See the slide?
We can see the screen.
Okay, all right. Let me just, okay. Okay, hi, welcome again. So this is our first webinar for clinical toxinology for this year. For those of you who attended, I think last year, Dr. Zaina did the first presentation on the snake bite management in Malaysia. So today, for some of you, it might be a repetition or might be just a refresher. But to those of you who have not been exposed to snake bite, or maybe snake bite is something that is new, or maybe you are scared of to see cases of snake bite before. So hopefully I can give a little bit of light to you all to be familiar with snake bite. All right, so my contents of my presentations or my sharing today will be a little bit go through very quickly on type of snake related injury. As we all know, sometimes it's not due to the bite, sometimes can be due to venom spread by the snake. Okay, so I will quickly cover the snakes of medical significance in Malaysia and how do we approach a patient with snake bite or snake related injury. And most importantly, we hopefully that at the end of the lecture, we can take back what are the symptoms or signs of envenoming and how do we monitor them. Okay. Of course, within this 1 hour, I can't really go in detail, but hopefully I can give an overview of that. Okay, and last but not least, some special consideration pertaining to snake-related injury. Okay, so as I mentioned earlier, snake-related injuries. Okay, this is a new, relatively new terms. Okay, for some of you. So it comprises of several things. Firstly, snake-related injury can present with local envenomation. Okay, even worse, they can present with systemic envenoming, or they can also have both local and systemic envenoming. They can also present with isolated venom ophthalmia, which is the venom being sprayed to the patient's eyes, and other related injury, for example, open wound in the cases of python bite, or maybe the wound has been manipulated. For example, the patient or the victim did an incision over the wounds. So that would also cause a unnecessary manipulated wound. And also unfortunate for some, we encounter being strangulated by the strong, big python. Okay. All right. These are the so-called families of snake of medical significance in Malaysia. Mostly elapids, vaporidae, they are venomous. Although some of the bites sometimes only give a minimal venoms. But just to throw some pictures, okay, and under the family of elapidae, we have king cobra, the biggest snake, cobra, which is a Naja species, crate, Vulgarus fasciatus, and also Vulgarus candidus, which is not here. We also have sea snake, as we all know. We should assume all sea snake are venomous. Okay, and we also have coral snake. Though the name are coral, but they are actually not situated in the coral or in the sea. Okay. Next, we have the major group that causing a lot of morbidities. Okay, is vaporidae. Okay, at the northern area where I'm practicing now is basically we are dealing with a lot of Malayan pit viper, which is the Calocelasma rhodostoma. And I'm sure those working in Cameron Highland are very familiar of this snake. Okay, Cameron Highland pit viper. And we also have Oposis and also Tropidonomus species. I'm going to talk a little bit at the end about Tropidonomus species because there are new evidence, a new publication pertaining to that. And we also have Natricidae, which also can give a significant envenoming, okay, if bitten by that. Okay, and although python is not a venomous snake, but they can cause a significant injury, okay, especially to the wounds locally, and also if being unfortunate, then even can strangulate to death. Okay? So how do we classify, or we break it down into whether how fast the venom or how severe the severity of the snakes. Okay, so we have venomous and rapid killer. For example, king cobra, cobra, kraits, and sea snake. While rapid killer mostly are due to the neurotoxin, which they can cause paralysis and even death if the victims are not sent to the nearby hospitals. Okay, and the next group we have venomous snake, but they are slow killer. Okay, usually they are slow releasing venom, which is pit viper, for example. They don't immediately presented with straight away deranged coagulation profile or full blood count. It will take some time. Okay, but they are definitely venomous. Same goes to the redneck skillback. Okay. We also have venomous snake, but with very minimal effect. For example, coral snake and our special Tropidonomus subannulatus, which is very common encounter in Malaysia and even Sabah and Sarawak. Okay? And as I mentioned earlier, non-venomous snake python, although they are not venomous, but they can cause significant injury or morbidity. And finally, quite a common encounter, bitten by a colubridae, which is non-venomous and non-dangerous. For this type of snake, we can just manage the wound and discharge from the ED or the KK. Okay. All right, these are the 5 top venomous snake being consulted over the years for the REX. For those of you who have not heard of REX before, there is actually a remote envenomation consultancy services. It's a voluntary 24/7 services provided. Okay, so these are the 5 most common snake. They are not in order, by the way. Malayan pit viper, Naja cortea, Naja sumatrana, okay, Tropidonomus Tropidonomus species, and also your mangrove pit viper. Okay, and the top non-venomous top 5 non-venomous snake consulted: the pythons, Homolepsis buccata, Lycodon, and also the Colignatus radiatus, and also your Hypopsis or Enhydris pelamba, Hypsiscopus pelamba. Okay. Okay, this is actually a quick overview of how do we approach whenever we have a snake bite victim. Okay, before arrival to hospitals, we recommend a good first aid being applied or being given to the patients or victims, and we should get an adequate, complete history pertaining to the bite, and also if possible, we should assist or try to get the possible ID of the snake by picture, or if the snake been killed at the site, to be put or keep in the safe container and transport to the hospital along with the patient. Okay, and most importantly, once patients arrive to us, so we need to recognize what are the envenoming signs and symptoms and perform a focus assessment, focus and serial assessment and monitoring. Okay, be it clinically or be it laboratorily or with serial investigations. And then come to the next question, whether the patient need, besides the general treatment, whether the patient need antivenom or not. Okay, and after given antivenom, the assessment do not stop there, and we must assess whether is there any needs to top up or is antivenom is enough. Okay, this is a simple, simplified do's and don'ts for first aid. So I'm sure some of you have seen this before. Just to highlight on the don'ts part, this is really still quite a number that we encounter, especially thigh ligature, which is patient tend to tourniquet the bitten limb. Okay, why tourniquet is really not recommended? Because it can affect our clinical assessment. It can worsen the swelling. Okay, so whenever it's being released, so you can see the swelling rapidly progress. Okay, so the patient also tend to apply all sort of traditional herbal paste, turmeric and ointments, etc. Okay? Okay, by sucking and cut the wound, you may introduce unnecessary infections. Okay, right. This is one of the recommended first aid, which is called PBI or pressure bandage immobilizations. It's mentioned in the WHO guideline. Usually what we want to do is we want to stop the venoms, to retard the venom transfer, because as we all know, the venom travel along our lymphatic drainage. So what we use here is actually we apply a bandage, not using the we use a special elastic bandage, okay, not our usual crepe bandage, okay, and then we tie along the limb, okay. But this is not to be done in the cases of pit viper or those elapids, for example, Naja, that produce local tissue necrosis. It's useful for example, a sea snake case or those elapids that require a long transport time to the hospitals. Okay. In patients with snake bite, before we start managing them, it is vital for us to get a detailed history. Okay, when I say detail, we want why is detail. If you ever consult Rex group, we usually tend to ask what was patient doing during the incident, where is the location. It's actually a purposeful questions, because for example, location of the incident, it will determine sometimes the geolocation of the common snake that is indigenous in that area. Okay, and whether the patient has have done anything to the bitten site. This is also can affect the wound, whether the swelling is worsened by that manipulation of the wound, bitten part. Okay, and if possible, try to get the picture of the snakes. Okay, okay. So next, you get the history. The next big thing that can assist us, especially the clinicians, okay, is the snake identification. Okay, for your info, there is no simple rule for identifying venomous snakes actually. So the best is from the hepatologist. Okay, but as we all encounter more and more cases, sometimes we can assist to identify the snake. Okay, and having a triangular shape, having a hissing sound, or probably the snake rise the head, that does not necessarily confirm it's venomous. Okay, so of course, if the victims or the patients or the first encounter clinician can provide such a 4 views or serial views of snake, for example, from the dorsal, ventral, from the lateral part of the head, looking at the eyes. This is really nice and can very much assist on the identification. But in reality, this is what we got. Okay, the head very smashed, the photo taken under a very bright light, and a very, very far away snake, which barely can be seen. Okay. However, without any snake picture or snake sample doesn't mean that we should not proceed or we cannot assess and monitor the patients. Okay, so the assessment and monitoring in snake bite, the main aim is actually to recognize the sign and symptom of envenomation, especially the systemic envenomation. And this will definitely help us to guide us whether the patient need antivenom or subsequently whether need to top up or the antivenom is already adequate for that patient. And remember, assessment and monitoring in snake bite is not a single process. It must be done serially and continuously. So if you break down into three main, the examination is general examination, specific to that specific examination, focus examination, and also examining the bite site. Okay. Remember, majority of the snake bite are actually unidentified. So sometimes we do not know what are the snake's ID. So syndromic approach, because certain, for example, Naja species, they can come with certain signs and symptoms, certain findings on the wound. So this is actually will help in terms of planning for the antivenom. Okay. So when we want to assess or monitor the symptom, we must know what are the systemic envenomations. Okay, that possibly happen in the snake bite patient. So there are four major toxicity: systemic envenoming, neurotoxicity, hematotoxicity, myotoxicity, and cardiotoxicity. Okay. So in neurotoxicity, the neurotoxins, okay, can cause or the patient can present with these signs and symptoms. The earliest one would be ptosis. So do examine the eyes of the patients, check the pupils, check the extraocular movement, and you can appreciate sometimes like this in this photo, there's a broken neck sign. Okay, the patient can also present with bulbar paralysis, cranial palsy, and abnormal breathing, and also aphonia. Okay, this is usually amongst the LRPD group. How about hematotoxicity, which recently the picture on the top right of the screen, we encounter a patient allegedly, possibly, most likely bitten by the Malayan pit viper, but the snake was not identified, by the way. But from the blood parameters, severe thrombocytopenia, platelet was 10, and deranged coagulation profile. So patient presented with severe or near respiratory arrest. While intubating, noted there is gush pooling of blood from the oral cavity. And as you can see, there are about 400 blood secretion coming out from the ETT. So this patient also was given antivenom. Okay, subsequently, what I heard yesterday, patient already been discharged, transferred back to peripheral hospital under room air. Okay, so other hematotoxicity symptoms or signs, they can also present with mucosal bleed, conjunctival hemorrhage, and even internal hemorrhage such as GI, urinary, and CT brain. Okay. Yeah, the top picture here, I think this is a case from Borneo, bitten by the green pit viper. So on examination, there is not noted is large bruise over the lower limb. The next systemic envenoming is myotoxicity. Okay, this is a case of bitten by a sea snake, where patient presented with generalized severe myalgia, muscle stiffness, and tenderness, and subsequently noted urine to be dark in color and complicated with AKI, acute kidney injury, oliguric acute kidney injury. And on top of that, patient also develop neurotoxicity. Okay. For cardiotoxicity, this is mainly pertaining to Naja species bite. Okay, how they can present, how can cardiotoxicity presented with? They can have arrhythmia or hypotension, and patient can be in shock. So baseline ECG is a must, especially in unidentified snake bite or suspected Naja bite. Okay. So moving on to the local envenoming. So the four common local envenomation signs or symptoms, of course, they will have a painful swelling. Okay, and in the case of Naja species bite, they can come with dermonecrosis. You can note there is also ecchymosis, okay, blistering, and enlarged and tender draining lymph nodes. For example, this is a serial picture of the local envenoming from Naja species bite. You can see if you do not examine the bitten site carefully, you might miss this small purplish paint color, discoloration of the toe. And subsequently, if you can able to trace, you can see there is the dermonecrosis expanding proximally to the dorsum of the foot, and over the days, it become more and more demarcated and hyperpigmented. Okay. This is another example. My encounter when I worked in Sarawak last time. So patient bitten immediately presented to ED. So describe the snake as black in color. So you can see there is a faint purplish, like bruising in color over the dorsum aspect. And over the 2 hours, it become more prominent and enlarging. And over the days, it develop a blistering, and the dermonecrosis expand to the lateral aspect of the ankle. Okay. So it's good to have a serial picture of the bitten site. Okay. This is a case of the Malayan pit viper, where they can present with actively oozing from the wound with multiple puncture wound and surrounding ecchymosis. As you can see, the hands and the finger, the little finger, there are 2 puncture wound at least, bleeding, and there are ecchymosis on the tip of the finger. Same goes to the third picture, very grossly swollen and got hemorrhagic blister. Okay, this is even an angrier looking swelling with hemorrhagic blister. Of course, this patient received antivenom, Malayan pit viper antivenoms. Okay, so where should we put our snake bite case? So ideally, it should be at least in yellow zone. And if you suspect ongoing envenoming, potentially patient might need antivenom. So it's best to manage in resus or critical zone. Okay. As for other critically ill patients, the approach is still the same: airway, breathing, circulation disability. Okay, and we should resus as per if the patient develop cardiac arrest. Of course, we need to do BLS and ACLS. Okay, and specific management that you want to apply, maybe apply immobilize the bitten part, bitten limb. Okay, and we shall recognize the sign and symptom of the envenomation as we go along. Okay, so how do we monitor? Okay, we know the local envenomation sign and symptom. We already know the systemic envenomation sign and symptom. So usually the systemic part is quite straightforward. Okay, but for the local envenoming, it can be a very difficult or very we are always in dilemma whether should we start antivenom or should we observe first. Okay, so of course, from the question, does all local envenoming need antivenom? Of course, no. But how do we assess or how do we monitor? The easiest bedside monitoring that we can do is actually rate of proximal progression. Okay, okay. I think to those that haven't done it before, you might find it a bit difficult, but it's actually not difficult. It's very straightforward. It's just that you need to have a serial, timing. For example, fixed interval of monitoring. So for example, I give you a clue. I give you an example. So patient presented to you, bitten over the foot. So arrived to you at about 19 hours, so 7 p.m. So you palpate the border of the edema. So this is the proximal border of the edema. So you mark there. Okay. So if you are not sure what time patient was bitten, it's okay. You can just start from the first marking. And then you review back after 1 hour or 2 hours. You noted the edema has progressed proximally. Then you palpate, you mark again the next border, proximal border. So you apply the subsequent label. Then you measure the distance by using tape or a ruler. Then you divide over the hours of your monitoring. So that will give you an RPP result in centimeter per hour. Okay. But just to note that RPP is actually a trend. We do not look at the single reading. So we want to know a few readings, then only we can analyze whether is it ascending, the rate is ascending, the rate is accelerating, static, or reducing. Okay, so that will give you a better idea of how fast the swelling is progressing, rather than a simple circumferential measurement or just a single reading. All right, then I'm sure if you ever manage snake bite, you will have come across this. All these are mentioned in the CPG. I'm sure in most of the ED is already available, the snake bite observation chart. So when you measure your RPP, so always note on the chart. So it's easier for you and for the managing doctor to analyze it, the trend. Okay. And apart from the RPP, not to forget the good friend pain score profile. Okay. So you want to know whether the pain is persistently severe, or is it reducing, or it still remain the same despite multiple doses of analgesia. Okay. So by looking at the PSP and RPP, that can assist us whether the patient needs antivenom or can continue to observe. Okay, and on top, below that, of course, there is a table for the serial blood result. Okay, but just to note that we should avoid drawing or painting over the bitten part. Okay, I know some of us still like to circle. The intention is to note where is the puncture wound or where is the bite wounds. But it's actually not necessary. Why? Because if you look at the marker there, if you use a thick marker, it can mask. I'm not sure whether there is any dermonecrosis underlying it, underlying your marking. Okay. And furthermore, marking by circling, surrounding, this does not really carry any meaningful any means. Okay, so it's just best to use a small thin tape to mark your swelling. Okay, and this is another example where we can improve using a thick tape. Okay, marking over the bitten part sometimes can also hide the underlying skin changes. See? Okay, so it should be avoided. And circumferential marking over the fingers or digit especially can act as a pseudo tourniquet and worsen the swelling of the finger. Okay, this also should be avoided. Okay, all right. This is another famous, famous dilemma. Okay, among managing clinician, swelling, pain. Sometimes the skin appear slightly purplish. Okay, is it ongoing impending compartment syndrome, or is this just a envenoming syndrome? Okay, as we all know, the pathophysiology of compartment syndrome, okay, the signs and symptoms of compartment syndrome, they will have all this. Okay, they will have numbness, they will have pain out of proportions. Okay, and they also have pain upon passive stretch test, tense over the limb, and also patient are definitely unable to move or we have a limited movement due to pain and swelling. However, okay, the pathophysiology behind it is different. Okay, compartment syndrome is because of the ischemia, but in snake bite, what is actually happening is the cytotoxic effect. Okay, as a direct cytotoxic effect from the venom itself. So it can also cause all the symptoms that are present in the compartment syndromes. But just to note that always think of the antivenom first rather than subjecting patient to the unnecessary fasciotomy. Okay? Okay, so I'm sure it's not that easy to decide. Okay, of course, limb threatening, we are trained to think of avoiding or detecting limb threatening conditions. Definitely, compartment syndrome is one of it. But I think now the focus have already, I mean, our management have already evolved. Okay, now we are looking at more and more evidence of the role of ultrasound or point of care ultrasound in snakebite patients. So I'm sure, I think if you have come across, I think some of the literature or publications, I think involve our great Prof. Ahmad Khaldun. Okay, among all these four, one of two, I think from Taiwan. I think one is based in Qatar and London, I think. So what are their conclusions mainly? Their conclusions, mostly they conclude are doing point of care ultrasound in snakebite can actually identify or assist in monitoring of the edema. Okay, it can locate the edema border better, and it can also by using POLES, I'll share about POLES later, also assist in whether is there signs of sonographic signs of the compartment syndrome. Okay, by using draft method. Okay, whether is it ongoing compartment syndrome. Okay, and the thirdly, using point of care ultrasound can help to assist whether this patient is especially looking at the RPP, whether this patient need an additional antivenom. Okay. So this is what I think to most of us is still new, but it's already been practiced quite some time, what we call as POLES, okay, focus for local envenomation from snakebite. Okay. So there are three methods, okay, in POLES. Number one is localization. What does it, I mean, localization, what do we localize? Is actually you want to localize the level of the affected tissue, okay, by using a linear probe, okay, we shall expect to see a cobblestone sign. If the affected tissue is located above the fascia, so there is less likely to cause acute compartment syndrome, okay, and we can also localize the margin between the edematous tissue and the normal tissue, as noted in the picture below. You can see the cobblestones, and then subsequently, there is no cobblestone appearance. Okay. Method 2, we are using POLES to assist us in determining RPP pattern. Okay, you know, sometimes we are a bit confused or we cannot really feel the border of the proximal border of the swelling. So point of care ultrasound can assist on that. Okay, so same, we scan through the swollen part, and like today we find the margin between the normal and abnormal appearance. Okay, and if we do it serially, then we can tabulate on the chart, then we can see whether the RPP is rising, accelerating, or is actually reducing. So this will guide us whether to top up antivenom or not. Okay. And thirdly, this is what we call draft, okay, diastolic retrograde arterial flow. So we need to measure, we need a Doppler to do this, and you can use your linear probe. You measure the Doppler wave over the compressed artery, the area of the swollen area. Okay, so when you put it on the systolic diastolic wave, normally it is expected your diastolic wave to be anterograde. Okay, but in the abnormal, in the very swollen limb or tissue, you can see there is a retrograde, okay, wave of the diastolic wave. Okay, so this can possibly give a clue whether this patient is actually potentially having acute compartment syndrome. Okay. All right. Okay, so apart from the assessing local progress of the swelling or envenomations, so of course we need to do some investigations, laboratory investigation for snake bites. So these are the list, and why do we need those investigation? FBC for obvious reason with coagulation profile. If you suspect hematotoxic species, then you need to evaluate. See the platelet, the hemoglobin, and you see your APTT, PT, and your INR. Okay. In the case of suspected myotoxicity, renal profile and CK serially are very important. This is to watch out for the presence of acute kidney injury with rhabdomyolysis. Okay. And in some snake bite patients, there is a presence of mild hepatic dysfunction as well. Okay, ABG to assist your respiratory function, whether your respiratory muscle are affected, and also to see any evidence of metabolic acidosis in the case of acute renal failure. Okay, and in the Naja species especially, is a must to do a ECG to see any arrhythmia or not, and urine for myoglobin and hematuria. Okay. And at the bottom there is 20-minute whole blood protein test, fibrinogen, and also the D-dimer. So for 20-minute whole blood protein test, okay, is useful in the case of, for example, your hospitals, or you are working at a very remote klinik kesihatan, okay, where you cannot do coag, you cannot do FBC, and you suspect patient possibly bitten by the green pit viper. Okay, so you want to do a quick test, okay, using a dry clean glass tube. So you can put the blood, leave it there for about 20 minutes and try to tip whether it's clot or not. Okay, so this is, I think, useful in the event of you cannot do your FBC or coag. If you can do coag and FBC, is not recommended to do a whole blood 20-minute clotting test. So how about monitoring? I mean, do we just do bloods at once, or we need to do serially? Depends on the whether, number one, whether the snake is unidentified or is already confirmed identified the species. Okay, if unidentified, if there is ongoing swelling, ongoing symptoms and signs, so we advise to monitor at least 6 hourly. Okay, if you already confirm or syndromic or clinical syndrome suggestive of pit viper or hematotoxic species, so you can just repeat FBC, coag, and CK 6 hourly. Okay, and if you happen to get bitten by a Naja, so you don't need a FBC or coag. Maybe it's just a baseline or daily, but you need a serial CK. Serial CK can assist on deciding the local tissue injury, especially if there is significant local tissue swelling or necrosis. This is actually important in the first 24 or 48 hours post-bite. So having monitored the swelling, having monitored the blood test, so now next come the big questions. Does patient need antivenom or not? Or should just treat conservatively without antivenoms? So these are the indications for antivenoms. We have systemic envenoming and local envenoming. Okay, hemostatic abnormalities. If patient is already like the case that I encountered recently, come with profuse bleeding, uh, uh, then even without the blood, we should consider if we know that it's possibly based on the geolocations of the incident site and then the clinical parameters. So most likely, patient will need antivenom. Okay, if patient present with neurotoxic sign, ptosis, and even leading to paralysis and even sometimes cardiac arrest, so you have to see the wound, any dermonecrosis. If even without a snake, you see there is a local clue. So most likely this patient is bitten by the Naja species. Then you might want to give Naja cortea antivenom. Okay, and of course other cardiovascular abnormality mostly caused by the Naja species. And if any signs of rhabdomyolysis, bitten in the sea, okay, so most likely is a sea snake envenoming. Okay, for local envenomation, indication for antivenom is a bit tricky. I think needs more experience. It's not just about progression, very slight progression, then choose antivenom. So as I said earlier, we need a serial observation and correlating with the pain, and also maybe guided by your CK as well. Okay, but there are some indications, for example, increasing local tissue necrosis, dermonecrosis, significant pains and wounds, or especially if bitten over the digits, toes and fingers, you might want to lower your threshold of given antivenom. Okay, this is these are the antivenoms that are available in Malaysia. Okay, so commonly used one, Najacotia antivenom. Okay, Malayan pit viper, GPAV. Like in Borneo, they don't have Caloslasma rhodostoma, and they also I think they don't have mangrove pit viper as well. So it's just adequate to keep the green pit viper antivenom in Borneo. The arrow here I want to highlight, I think in the previous CPG that we have, it is mentioned 4 vials, but it's actually 3 vials for the local and systemic antivenoms. Okay, so once you decide the patient needs antivenom, so how do we do it? How do we give it? Okay, just quickly, it's all being given IV. So far, we do not give locally or we do not give IM. Okay, the most important part is actually how do we prepare, dilute, and how much fluid to be diluted. Okay, so if you, for example, you get 5 vials of Najacotia antivenom, so you get all the freeze-dried antivenom mixed with the 10 ml of water for injection. The most important step here is please make sure do not to shake the vial. Just gently swirl to dissolve the antivenom. And when you have all the 5 vial diluted or reconstituted, then you further dilute all the 5 vial into, for adult, 250 or 500 or 1 pint, or for pediatrics, you just total up the 50 ml plus another 5 to 10 ml fluid for the kids. Okay, and we no longer practice using test dose. However, what we do is actually we start off with a slower rate. For example, 1 to 2 ml per minute, which is about 60 to 120 ml, 120 ml per hour. Okay, over the 10 to 15 minutes. Then if there is no reactions or allergy, then we aim to complete within 1 hour. Okay. Ideally, it should be given in the close monitoring area and with all your resusc trolley resusc equipment on standby. Okay, especially the adrenaline in case patient develop anaphylaxis. Okay, and once completed, how do we observe or do we monitor for the response? Okay, generally we will ask patient whether the pain is better, general condition, whether the pain feel better after the antivenom. Okay? If in the event of any systemic bleeding, you should expect to stop within 15 to 30 minutes. Shock to resolve or to improve after 30 minutes to one hour. And usually blood coagulopathy will be restored within 3 to 9 hours. That is why we do not recommend the blood to be repeated immediately after antivenom. Usually we recommend, especially the Malayan pit viper, GPAV, after 6 hours from the antivenom completions. Okay. Neurotoxic envenoming usually is quite fast improving as early as 30 minutes or up to hours. Okay. For rhabdomyolysis, acute active hemolysis, usually we take hours for the urine to return to normal and for the renal function to be normalizing. Okay. Of course, antivenom also possess reactions as early as minutes. Okay, after given antivenom, patient can develop anaphylaxis. Sorry about the typo, and also pyrogenic reactions. Late reaction will be serum sickness. Okay. So treatment of the reaction, of course, adrenaline, fluids, antihistamine, steroid, and also antipyretic. Okay. So when shall we repeat in case patient need to repeat antivenoms? So for bleeding or hematotoxicity, despite antivenom, the blood parameters are worsening. Okay, it will take some time. For INR, for example, the baseline is about 8, 6. Usually we tend to give when INR is above 5 if there is no bleeding. But if there is any significant bleeding, then any derangement we will give antivenom. So the blood parameter will be restored in hours. But in case if still worsening or patient still persistently bleed, then you must consider to repeat or top up antivenom. Or in the case of neurotoxicity, there's no improvement or any cardiovascular sign or toxicity. Okay. So other adjunct therapy, you can consider antibiotics. Not all snakebite need antibiotic. However, those we especially Naja species bite with significant tissue or dermonecrosis, we shall consider giving broad spectrum antibiotic. Augmentin or Unacin will do. Anti-tetanus based on patient's immunization status, and if patient bitten by the, for example, coral, okay, sometimes you might want to consider anticholinesterase, okay, neostigmine and atropine. Okay. On the right side, these are the things that commonly being given, but it's actually no proven effectiveness or even can be harmful. Okay, of course, traditional first aid I mentioned at the beginning of the lecture. Okay, steroids. Okay, giving prophylactic steroid or antihistamine for all snake bites is actually no clinical proven effectiveness. Okay, NSAID should be avoided, especially giving IM NSAID. Okay, as you all know, NSAID can worsen bleeding. Okay, heparin, of course, tranexamic acid, vitamin K, and blood products are not recommended to be given. Okay, antivenom is still the first line unless you do not have antivenom at your center and patient presented with massive bleeding in shock, then you might want to consider all your antifibrinolytic, vitamin K, or even FFP. Okay. All right, moving on to the last part of the talk is actually special issues pertaining to the snake-related injury or snake bite. Okay, so we mentioned about python, non-venomous snake, but it can cause a significant morbidity. So some patients unfortunately get a very significant lacerations, multiple deep laceration wound. So the management for this patient, okay, of course the wound, if there is bleeding, we shall stop the bleeding, clean the wound, don't forget your IM-ATT if it's already due, and patient need to be referred for debridement, proper debridement. Okay. And do not forget, okay, this is our case as well, being bitten by python. So there's multiple puncture wounds. So it's quite classic of the python bite. So when we do X-ray, there are multiple radio-opaque foreign body scenes, okay, probably from the retained teeth. Okay, all right. In the event of the Naja sumatrana, I mean, so far the only species that is I think causing venom ophthalmia is Naja sumatrana in Malaysia. So this is special local envenoming by Naja sumatrana. So it can be as far as 2.5 meters. They can spray the venom and right into your eyes. Okay, so patient will present with a very severe stinging pain with blurry of visions, and also hyper. They produce a lot of secretion, a lot of discharge. Okay, so the eye will be bright red, and they can have blepharospasm. Okay, so these are the possible effect from the venom ophthalmia. So what we need to do, number one is actually copious amount of irrigation, okay, by using normal saline, especially, okay, up to 5 to 10 liters sometime until the symptom improve, okay. And patient need to be referred to the ophthalm for a topical for a slit lamp under slit lamp examinations, okay. But however, please do remind our ophthalm colleague not to prescribe topical steroid. Okay, this can lead to the cornea melting. All right, so I think if you come across these publications by Prof. Khaldun, Dr. Zainal, and Dr. Sabina and team about the frequency, clinical characteristic, and also outcome of the Tropidodermus species bite and venomation in Malaysia. It's actually quite common. I think out of the cases consulted, I think about at least, I think almost 6%. I think, if I'm not mistaken, okay, bitten by the, they are almost the same. If you look at the on top, is actually Tropidodermus regulari. The top left is actually female. Okay, the top right is actually male Tropidodermus regulari. These are in Peninsular Malaysia. The bottom pictures are actually Tropidodermus subannulatus. The left one is female, the right one is male. These are found in Sabah, Sarawak, Borneo. Okay, they are almost identical in looking. Okay, right. So what are the conclusions amongst all the patients? Okay, so they have concluded that the bite from this species actually only cause mild local symptoms. Okay, so they do not suggest or recommend any antivenom for this species bite. Okay, I think previously there were 2 reported cases were given unnecessary antivenom for this patient. So management usually is symptomatic with adequate analgesia and probably a short period of serial monitoring. Okay, and then patient can be safely discharged. All right, so I think I'm coming to the end of my presentations. So if you need any assistance or any guide at any particular phase of managing a snake bite patient, remember we have Rex. We can offer help or consultations. So where or when that we can help you is actually right from the beginning, okay, or even to assist you in the snake identifications, to assist you whether this patient need to give antivenom or not, and also post-discharge care, and as well whether once patient is already admitted as inpatient, be it in medical, surgical, orthopedic, or even in the ICU, feel free to consult if there is need. All right, so in summary, most of these snake bites are still unidentified. Okay, so sometimes it can be tricky. However, snake bite, they do possess some clinical syndrome, or we can know from the syndromic approach. Okay, and it's important to know our common local venomous species so that we know what are the antivenom, because treatment of the significant envenoming is still number one, antivenom. Okay. Use of PLES or point of care ultrasound in local envenoming syndrome can assist us in monitoring and antivenom usage. Okay, I'm sure most of the ED, KKs now have portable ultrasound, so we can do very quickly, non-invasive, to assess more accurately. Okay, so and last but not least, do remember diagnosis of snake bite can be dynamic. Though in the ED, sometimes you diagnose as unidentified, subsequently patient develop a envenoming syndrome, or even patient brought the dead snake or at least managed to get the picture. So please do revise and update your diagnosis. And remember, if you need guidance, remember we are here. Okay, with that, thank you very much. And selamat berpuasa. I hand over to the moderator.
Okay, thank you, Dr. Anas Amri, for the comprehensive presentation of at least the initial management of snake bite, and also up till the subsequent treatment with antivenom, including the supportive or adjunct therapies for snake bite and its complication. So we also welcome our counterpart from all other ASEAN countries, includes from Indonesia, Singapore, Japan, Vietnam, and forgive me if I am not actually mentioning any other ASEAN countries around. Um, so we are overwhelmed with a lot of questions over here in the Q&A box. So I shall actually pick a few questions. So if the questions that I didn't pick, that is because of our limitation of time. So you can actually email to us if you want your question to be answered later on. Okay, Dr. Anas, are you okay? You need 2 minutes? No need.
It's okay. Can
Okay.
proceed.
So basically, there are one questions that actually asking about the hematotoxicity. So if let's say the patient is actually demonstrating abnormal coagulation profile, but without any evidence of bleeding from orifices, or actually, I presume, yeah, without any presence of bleeding. So, how would you actually treat the patient? Is it common in our setting?
Yes. Okay. Thank you, Dr. Sabrina. Actually, it's quite common. Especially once patient admitted to the ward, bitten by, for example, green pit viper or Malayan pit viper. Initially, blood result were normal. Then subsequently, serially, 6-hourly showed the range in coagulation profile, and then also the thrombocytopenia, mean platelet. So, and even sometimes they will have a bit of raise in white blood cell due to reactive leukocytosis. So for this hematotoxicity without any bleeding, we usually there is role of there's role of continuing observation. I mean, with serial blood. But however, if the level is severely deranged, usually we take as INR above 5 and also platelet less than 100. Okay, and APTT if really cannot, sometimes it's not readable, so you might want to consider giving antivenoms. But in the event of post antivenom, meaning that already given antivenom at the beginning, and then sometimes it develop a recurrence. So sometimes the recurrence is due to the depot effect. So we can just observe with serial blood, and then making sure that the patient is strictly immobilized in the ward or keep strictly bed rest rather than ambulating. Okay. That is my thought, Dr. Sabrina.
Yeah, because I think bed rest, strict bed rest is very important because if we see the molecular level of the pit viper venom comparing to the neurotoxic venom, is actually bigger in a pit viper species. So if let's say initially initially there might be some form of actually swelling, particularly in a pit viper lah kan. So if let's say the swelling is subsided, the patient is actually walking around. So like Dr. Anna said, there are things that we call as depot effect. When the patient actually is walking around, and that is when we usually see the coagulation derangement because of the depot effect lah. So there are other questions. It is asking about regarding the RPP. Do we measure proximal progress of the proximal progression from the bite side? Do we also measure distal to the bite side?
This is I think from Hood Azaki. Okay, we are more interested in proximal progressions. As we all know, venoms travel via the lymphatic drainage. So expectedly, the swelling to be progressed proximally rather than distally. But depending on your site of bite, sometimes patient is bitten over the back or over the scalp. So so sometimes it's a bit difficult where to measure, or we just measure how the swelling expand from the bite wounds. So to answer that, usually we only measure rate of proximal progression. We don't measure distal progressions.
I think in real life situation for the RPP, it is actually much more easier if the patient, literally, if the patient is actually being bitten at the upper limbs or limbs, right? But once the patient is bitten, for example, at around the head or neck region, the torso region, it is obviously a bit difficult for us to assess in the terms of RPP. So that's why other than that, actually the torso, when the patient is being bitten at the torso or head and neck, actually there are a lot of things, other things to consider, right? For example, is the swelling actually circumferential or involving other organs that we need to consider giving antivenom, right? Right. So I think we have got one question. I think this is I'm not sure whether from our klinik kesihatan or rural area, we can help him to answer one of his question from Maurice Lasum. He actually is asking about in case of the patients is actually having diabetes mellitus and been bitten by a snake, whether it's venomous or non-venomous. For example, in the leg, on the leg. So is it can cause was it can cause the patient to have sepsis or is it can cause a bad prognosis for the patient? And what is the management that we need to do if this case is actually happen in a rural area, far away from facility that having an AV?
Okay, thank you, Maurice Lasem. Okay, wassalam. Actually, any animal bites do possess a risk of infections. But however, so far that is based on the evidence base from the Snakebite, I'm sure DM is actually one of the predictors for immunocompromise and the risk of infections. However, if the bite, I would say I would analyze the bite wound itself. If there is not significant puncture wounds or not significant laceration wound, not significant openings to the wound. I mean, the wound is very small, minute, or barely seen. So I think for that particular patient, that there is a role of observation. I mean, we can discharge the patient with advice, not necessarily to be treated empirically with antibiotics. But if the diabetes is very not well controlled, and you are very concerned that patient always get a recurrent skin infections, the skin are not in good conditions, I think no harm started on antibiotics for that particular, especially if the wound is big enough. If the wound is just very barely seen, there's no obvious puncture wound, I think it can still do without any antibiotics. And if let's say the patient presented, another thing that you must ask the patient whether has there been any manipulation, whether the patient did puncture using any foreign body, apply anything to the wound. That is also a predisposing factor for secondary infections on top of that primary snake bite wounds. That's my thought, Dr. Sabina.
Yeah, thank you. I think got a lot of questions from Dr. Ahmad Khaldun. We will pick one lah kan. So from Professor Kamadia, Dr. Makadun Ismail from UKM. So is there any role for white blood cell count
Yeah,
snake envenomation?
dari Prof saja ni. Ya, Prof. Usually, apa role of WBC? Normally, in bite patient, snake bite patient, we see a slight elevation of total white, basically due to reactive leukocytosis. However, the role of monitoring it is also vital because especially if there's significant local tissue necrosis, we want to monitor for any a secondary bacterial infection. So yes, WBC is important. And sometimes in bleeding, significant bleeding also, you might get leukocytosis as well.
Okay. I think I can allow for we still have a lot of questions. Okay, now I will actually allow you to pick one question that you would like to answer from the Q&A box.
Okay, I would like to answer because this is quite important. Another question from Prof. Khaldun. Is there any clinical guides that discuss the appropriate wound management post snakebite envenoming, management of cytotoxicity, including the best timing for surgical debridement and how and when to decide? Okay, I did come across. I mean, in the guideline in the CPG, I'm not sure whether it's mentioned or not, but for the especially cytotoxicity, for example, Naja species bite producing the more necrosis. So the best timing usually we will allow up until day 4 to day 6 because from day 1 until day 4, the more necrosis is still expanding. Sometimes we do not see the demarcation of the monocrosis very well at the earlier phase. So going in for debridement prematurely might result in you need to do a second or even third debridement. So significant cytotoxicity, yes, there should be a surgical intervention. Usually there will be. However, a small one we still can do with conservative and wound review serially. Okay. So the best timing for subject patient for debridement is usually after day 5 onwards, probably, unless the patient develop abscess collection or turn into sepsis earlier, then they should be referred early for surgical interventions. Okay.
One question about antivenom efficacy from Anonymous. He asked about, does antivenom show efficacy in reversing local cytotoxic symptoms? Literature review is controversial.
Okay, to be honest, I'm not too sure about evidence base for this, but what I understand is usually what we do. Usually when we give antivenom for example the monocrosis, correct me if I'm wrong, Sabrina, is not actually to stop it from progressing, but it's actually rather than uh, how to say, it's already there. The democracy is already formed, so we are not actually preventing it from expanding. Am I right, Dr. Sabrina?
Monocrosis is actually a the tissue death already, cell death. So we cannot reverse the cell
Yeah,
death.
cannot reverse. Yeah.
Thing can actually reduce the rate, the swelling from progressing upwards, and also from spreading lah.
Yeah.
Those
So the keyword is we do not reverse the monocrosis. Back to healthy normal skin. So we just might prevent the swelling or the local extension is from worsening.
Okay, I think we are actually quite exceeding time till 4:15. We are actually thanks Prof Penam Palam from Singapore, who actually is asking one questions. This might be the last questions. Prof Penam Palam actually asked about what is the significance of ascending lymphangitis in envenoming risk assessment. This is a bit difficult answer, difficult question lah, yeah.
Yeah. Okay. I think significant ascending lymphangitis in envenoming. Okay. I think if there is ongoing envenoming from the snake bite, so whenever it's already up to your, the nearest draining lymph nodes, So it indicates that the venom is already spreading, if I'm not mistaken. Correct me also, Dr. Sabina. So usually, but that is not a sole indication for us to start antivenoms. We That is a guide, that is a clue, that is significant local envenomation, but however, it's not a sole marker to be used for initiation of antivenoms. And we will look at the RPP, the pain score profile, and also a local tissue injury or necrosis.
Okay. Yeah, I think that is all the time that we have for now. I would like to thank Dr. Anas Amri bin Hashim for his very good presentation and been bombarded by very lot of questions over here. So anyway, now I will share the link for the registration and e-certificate. Just now, in the initial webinar, I've already shared regarding the APMT 2024 conference that will be held in Penang, Malaysia in November. So I will actually point it again later on. So feel free to submit your abstract for this year's APMT 2024. We will be glad to see you around. Wait a minute when I will actually share the link for the registration.
Sorry, Dr. Sabina, if I may say a word. So for those questions,
Can.
that we cannot answer just due to time interest, feel free to email us. Can email me dranasambli@gmail.com. So maybe I will reply from there. So sorry that we are running out of time. There are too many questions. Thanks for joining, by the way.
Okay. I've already shared the link for the registration and e-certificate. Since this is a e-certificate has a limitation per day, so if let's say you didn't get it, please allow us to actually send you in 1 week's time regarding the e-certificates. If not, then you can actually email us at clinicaltoxinology@gmail.com. Okay, with that, I thank you for your kind attention, and we'll be seeing you guys again hopefully in June 2024. Thank you, everybody. Thank you, Dr. Anas, for excellent presentation.
Thank you, Dr. Sabina. Thank you, Prof. Khaldun, and all the rest.